My name is Emily, and I'm a nursing student at Glacier Hills Care and Rehab Center, and I'm going to present a patient now. Patient is a 65-year-old married Caucasian male. His previous occupation was as a mortgage banker, but he is currently retired. His usual source of care is the West Ann Arbor Health Center, or Hospital. Chief complaint was pain and tingling of the lumbar spine. This led to a laminectomy of L1 to L5 and a discectomy from L5 to S1 from a herniated disc. Patient had been experiencing lumbar spine pain for 25 to 30 years. He rated his pain as a 4 or 5 out of 10 when aggravated from extended walking. Alleviating factors were to sit and stretch. Patient treated with hydrocodone tablets and occasional visits to the spine clinic for cortisone injections. He reports that the pain did not affect ADLs such as household chores, but he was forced to give up golf and physically demanding chores such as mowing the lawn or cleaning the gutters. At the time of examination, pulse was 88 and respirations 20. Past medical history includes hyperlipidemia, hypertension, a left bundle branch block, obesity, spinal stenosis, anemia, peripheral neuropathy of the left foot, also known as drop foot, and osteoarthritis of the knee, back, and hands. All immunizations were updated, and no known allergies were reported. Previous hospitalizations and surgeries include the laminectomy and discectomy, right knee arthroplasty and knee replacement, and a cholecystectomy, which led to a case of pancreatitis. Current medications include acetaminophen, docusate sodium, oxycodone, lisinopril hydrochlorothiazide, simvastatin, and tamsulosin. Functional assessment. Patient reports drinking 3 to 4 glasses of wine a week and occasionally smokes cigars. Patient used to smoke 2 packs of cigarettes per day for 25 years, but quit 23 years ago. Exercise includes using the elliptical machine for about half an hour a day. Patient reports disturbed sleep due to a throbbing pain in his shoulders, which he rates as a 6 out of 10. Diet is healthy, and caffeine intake includes about 6 cups of coffee each day. The patient has been using a cane for 5 years for stability when walking. Psychosocially, the patient is stable and reports a good family dynamic. He lives at home with his soon-to-be retired wife. He rates stress as a 5 out of 10 about finances due to his recent retirement. The patient has no religious practices. Patient's educational level was a BA, double majoring in English and Fine Arts. His pattern of seeking health care is an annual physical or when necessary due to illness. Patient reports that his father died at age 90 from pulmonary fibrosis, experienced minor heart issues for 25 to 30 years, had a knee replacement, and back surgery. Patient also reports his mother is 100 years old, living with dementia. She has spinal stenosis, but due to her age is unable to undergo surgery. Musculoskeletal. Patient's daily activities are only altered by use of a cane when walking. There is a family history of osteoarthritis in the hands, which the patient currently experiences, as well as in his shoulders and knees. He rates his joint pain as a 4 when in use. Pain management is the use of hydrocodone medication. He first noticed the joint pain in his hands about 5 years ago, but reports shoulder and knee joint pain longer than that. He states that he only notices the symptoms getting worse with the absence of his medication. Patient is currently doing daily physical therapy at Glacier Hills, but enjoys using his elliptical machine because it doesn't cause him pain. In the past, patient broke his left wrist, a bone in his lower leg, and 2 fingers. He has noticed gradual loss of muscle strength in the past couple of years due to decreased activity from his back and knee pain. Patient reports falling about twice a month in the last 6 months from his drop foot catching and causing him to lose balance. On inspection, muscle mass and bone structure appear symmetrical. Posture is slightly uneven, with the left shoulder slouching. Patient's gait is normal and even, but assisted by a walker since his spinal surgery. Scoliosis couldn't be assessed due to recent surgery. Assessment of the joints revealed minor limitations in the neck with hyperextension and lateral movement, limited flexion and hyperextension of the shoulders, pain with circumduction of the wrists, arthritic pain in the thumbs, and limited dorsiflexion and circumduction of the left foot due to drop foot. Range of motion in the spine wasn't able to be tested due to recent surgery. There was no erythema, inflammation, warmth, or pronounced crepitus in any of the joints that were assessed. All muscle strength tests were graded at a 5, with the exception of the left foot dorsiflexion, which could be graded at a 3. Cardiac. Patient reports that no ADLs are restricted from his cardiovascular issues. Patient states that both parents had issues in their 70s or 80s, which were never a primary concern. His mother had a malfunctioning valve, and his father had an arrhythmia. Prior to spinal surgery, the patient weighed 320 pounds, but currently weighs 305. Before that, he had lost a conscious 30 pounds from changing his diet. The patient has been diagnosed with a left bundle branch block, which was discovered from an EKG prior to knee surgery. Patient reports no history of cardiovascular infection, and he states possibly having rheumatic fever at around age 6. Patient has had multiple EKGs, a stress test, and a heart catheter, which all revealed no further problems. Patient reports having hypertension with a systolic measurement of at least 150. Since his surgery, however, he reports having a blood pressure of 115/65 under current medications. There were no obvious lifts or thrills on inspection and palpation of the chest. AP transverse diameter was 1 to 2. S1 and S2 sounds auscultated normally, with no evidence of S3, S4, or any murmurs. According to the American Physiological Society, it is important to assess the respiratory system because of this patient's history of smoking tobacco. The APS reports that active exposure to cigarette smoke likely accounts for 80 to 90% of chronic obstructive pulmonary disease in the United States. Inhalation of cigarette smoke incites acute and chronic inflammatory responses which potentially cause alveolar destruction, promoting emphysema. According to the American Academy of Dermatology, obesity is implicated in a wide spectrum of dermatologic diseases and issues. Due to my patient's current weight status, it is pertinent to perform an integumentary system assessment to check for pressure ulcers or lesions under any skin folds. Also, the AAD reveals that animal studies associate obesity with altered collagen structure and impaired wound healing, which is concerning considering my patient's fresh incision from spinal surgery.